Welcome back to the Deep Dive, where we take your source material, the dense articles, the clinical notes, the raw data, and turn it into knowledge you can actually use. Today, we are undertaking a really critical deep dive into the technology that has just fundamentally changed breast cancer screening over the last decade: digital breast tomosynthesis, or DBT.
You probably know it as 3D mammography. And the core mission here, based on the studies you sent over, is a really comprehensive two-sided analysis. We're looking at DBT, which, is almost always used with standard 2D digital mammography. We have to see the verifiable wins, how much clearer the tech makes the cancer, a measure called Conspicuity. But, and this is just as important, we have to dissect the case reviews that show us why, even with this amazing tech, cancers are still being missed.
And the quantitative results, they're striking right out of the gate. We are not talking about small marginal improvements here.
Not at all. The major trials comparing 2D mammography versus the DBT and DM combination, they show this huge shift in screening performance. Yeah. If you look at massive data sets, I'm talking about the Oslo trial, the big JAMA retrospective analysis, the evidence is consistent globally. When screening included DBT, there was a consistent 15% reduction in the recall rate.
And that reduction is huge for the patient experience. A recall means you get that dreaded phone call, you have to come back.
Exactly. It often leads to biopsies, incredible stress, and of course cost. So cutting that false alarm rate by 15% is a massive win for everyone.
But the detection numbers, that's where my jaw dropped.
That's right. Those are the real headliners. Across those same large trials, DBT screening led to an overall 27 to 29% increase in the total number of cancers found.
And here's the number that should really jump out at you. These trials consistently recorded a massive 40 to 41% increase in the detection of invasive cancers.
And that's the whole point. That is the critical metric. Finding the cancers that have started to spread and finding them earlier and more often. Right. That's the goal of any screening program.
Right.
And we see this mirrored everywhere, even in smaller, more localized experiences. For instance, the Penn Screening Program review showed their recall reduction was right in line, around 16%. But they specifically noted a really strong increase in detection, like 3.6 per 1,000 screened for women under 50. And that's often a more challenging group to image. It just confirms this is a genuine paradigm shift.
Okay, so let's unpack this. Why is DBT so much better at generating these numbers? Why does adding that third dimension suddenly reveal things that 2D couldn't?
The answer is all in that concept we mentioned earlier, conspicuity. Think of a traditional 2D mammogram like a single flat photograph of a pile of books. The books are there, but their edges and spines are all overlapping, making it impossible to read any one title.
It's just a lot of confusing shadows and clutter.
Exactly. It stacks all the tissue planes on top of one another. DBT, on the other hand, takes multiple images from various angles, 15, maybe 25 separate pictures, and then the computer reconstructs virtual slices of the breast tissue.
So it's like digitally separating those books one by one?
Precisely. You can see specific structures clearly without all that overlapping confusion. It just minimizes the noise.
And these sources confirm this visual advantage dramatically.
They do. Multiple studies where radiologists literally grade how easy it is to see a cancer show that they were consistently and significantly more conspicuous on DBT than on 2D. The statistical certainty behind it was just overwhelming. This wasn't a small difference. It was proven, without a doubt, that DBT provides a clearer picture.
And that internal breakdown from the Penn study, the one that looked at 200 known cases, it really shows the lopsided fight between the two technologies. Cancers were seen better on DBT compared to DM, a staggering 48% of the time.
And contrast that with the inverse. They were seen better on DM than DBT only 12% of the time. So that's a 4-to-1 ratio. It just paints a crystal clear picture of DBT's ability to pierce through that obscuring tissue.
Okay, but here's where it gets really interesting. Even within the 3D world, even with DBT, the visibility depends heavily on the angle of the image. We're talking about the two main views, right? The CC and the MLO.
That's right. The craniocaudal, or CC view, which is top down, and the mediolateral oblique, or MLO view, which is from the side at an angle.
So which one is the hero view? Which one is dominant for catching these cancers in 3D?
Well, the data shows a really surprising pattern. When they compared the two angles, cancers were actually seen better on the CC view in 43% of cases.
43%?
Yeah. And that's way higher than the MLO view,
right,
which was only better in about 15% of cases.
Wow. So there's something about how that top-down compression unspools the tissue that's just critical for detection.
Precisely. And we have a perfect case example that illustrates DBT's biggest advantage, spotting what's called architectural distortion. This is often the most subtle sign of invasive cancer, where the normal tissue is kind of pulled or puckered, but there's no obvious dense mass.
Tell us about the case.
Okay, so you have a 46-year-old woman, routine screening. Her standard 2D mammogram was read as negative. All the radiologist noted was scattered fibroglandular densities, which is a totally normal finding.
So nothing alarming on the 2D film.
Nothing at all. But when the DBT view was analyzed, it revealed clear architectural distortion, these subtle, spiky pulls in the upper outer quadrant. And that one subtle finding led to the diagnosis of a huge 6-centimeter invasive lobular carcinoma.
6 centimeters, and it was completely hidden on the 2D.
Completely hidden. The surrounding healthy tissue was just obscuring that subtle distortion.
So the lesson here, coming right from the sources, is that detection isn't just about whether a breast is officially categorized as dense or not.
Exactly. It's about avoiding those confounding structures that overlap and hide these subtle areas. And DBT just separates the tissue planes, acting like a scalpel for the image, making those little spikes and pulls visible where they were masked before.
Okay, so we've seen the success stories. The technology is clearly superior, but, as we know, tech is only as good as the system and the person reading it. So let's pivot and look at the human factor. Where are the errors happening?
That's essential, because despite all this, cancers are still missed. We have to look at the failure rate. This one program review found that the symptomatic interval cancer rate, that's cancers diagnosed within a year of a negative screen, was still 0.5 per 1,000.
Which doesn't sound like a lot, but scaled up, that is hundreds of patients a year getting a false negative.
Yeah.
The stakes are still incredibly high.
Very high. And the sources neatly categorize these diagnostic failures into 3 core groups: errors in detection or perception, errors in interpretation or comparison, and then the truly DBT occult cancers that were only findable on other machines.
Let's start with those perception errors, because that's really about the reader's focus and psychology.
Right. And the cases illustrate these common cognitive pitfalls. Let's start with an error in detection caused by something called satisfaction of search.
I find this fascinating. It's a recognized failure mode of the human brain. How did it play out here?
So there's a case of a 73-year-old woman where a benign finding, a hamartoma, was clearly seen. The reader found it, identified it, and mentally kind of stopped searching. They were satisfied they'd found the thing.
And what was missed because of that premature satisfaction?
They missed a subtle adjacent mass, and it turned out to be an invasive lobular carcinoma, a very tricky cancer that hides well. The lesson from this is you can never, ever stop searching after the first finding. Multiple significant things can coexist, and being satisfied with that first discovery can lead to a fatal oversight.
And another one, the lack of perception case.
Wow.
A 49-year-old woman.
Yes, she was recalled for possible distortion, and the follow-up imaging was called negative. But 8 months later, she comes back with a palpable mass.
So what did they find when they looked back?
When the team re-examined the films, enlarged lymph nodes were clearly visible in the corner of the film from that original follow-up. But because they were outside the main focus area, they were just not noted.
The natural human instinct is to focus on the center of the image.
It is. But the lesson is so clear. You have to train yourself to look at the entire image right to the very edges. Cancer doesn't care about staying in the center of the frame.
Okay, moving on to interpretation errors. The difficulty of comparing subtle changes over time, that seems like a huge cognitive task.
It is. Take the case of the 54-year-old whose architectural distortion was clearly detected in 2013, which led to her diagnosis.
But the question is, why wasn't it seen earlier?
Exactly. That same distortion was missed on her 2012 screen. And here's the kicker. When they reviewed it retrospectively, the subtle change was, in fact, visible in 2012. You just had to look really closely. The failure wasn't image quality. It was an inability to detect that subtle progression year over year. That's why side-by-side comparison with prior studies is absolutely mandatory.
And then there's a clear error of interpretation. The 51-year-old where distortion was seen, but then dismissed.
Correct. It was assumed to be an old surgical scar from a biopsy that happened way back in 1979, decades earlier.
So the reader saw something, thought, oh, that's just a scar, and moved on. What was the flaw?
The assumption was the error. The new distortion was in the lower outer quadrant, but the original biopsy was in the upper outer quadrant, a completely different location. The takeaway for any physician is straightforward. Never make assumptions. Architectural distortion is highly suspicious and must be aggressively worked up, unless it perfectly matches a known, stable scar.
This brings us to that third category, the DBT occult cancers. This is where the technology itself, despite its clarity, just doesn't see the whole picture. It's fascinating that even with these massive improvements, DBT doesn't see everything.
That's right. It proves that imaging is just one layer in a multimodal defense. Certain cancer types or certain patient profiles absolutely require additional tools, no matter what the DBT says.
And we see this in cases where persistent clinical symptoms they trumped a negative screen. Tell us to the patient with diffuse pain.
A 54-year-old woman presents with diffuse pain and thickening in her right breast. Her DBT and her follow-up ultrasound were both negative. Everything looked clear on the images.
So the easy path is to dismiss the complaint.
But her symptoms persisted. So management correctly continued, and an MRI was done a month later. And that MRI diagnosed diffuse micropapillary carcinoma. The lesson is absolutely essential. Clinical symptoms must always guide what you do. Never let a negative scan, no matter how advanced, dismiss a genuine patient concern.
And what about our highest risk patients? Does the DBT screening interval even hold up for them?
Not always. Take the 49-year-old with a BRCA2 mutation, a patient already known to be at very high risk. Her DBT screen was negative, clean bill of health. But a screening MRI just 5 months later detected a new, aggressive 10-millimeter mass. It was a triple-negative invasive ductal carcinoma.
5 months. That just underscores the speed at which these cancers can develop in high-risk patients.
Exactly. The case just confirms that for those profiles, you need high-sensitivity tools like MRI to catch these fast-growing cancers while they're still small and treatable.
In fact, the source analysis confirmed it. After negative DBT screens, more cancers were found by MR in 3 cases and by ultrasound in 1 case.
And that ultrasound case is a perfect example of listening to the patient. A 53-year-old requested a screening ultrasound because she was worried about her dense breasts. But what's interesting is the DBT had actually read her as having scattered fibroglandular densities, which is not technically dense.
So the radiologist wasn't worried about density, but the patient was worried about her body.
Right, and that requested ultrasound, despite the non-dense categorization, it detected an invasive ductal carcinoma. It just proves that even when density isn't the primary challenge, subtle signs can still be overlooked.
So if we synthesize all of this, the main conclusion is it's undeniable. DBT significantly improves the sensitivity of mammography. It drives up detection, especially for invasive cancers, while cutting down on the pain and cost of false positives. It's especially powerful for revealing those cancers that were hidden on 2D films, specifically that subtle architectural distortion.
And we learned a critical technical detail. Cancers are most often better seen on the CC view of the DBT. That is a crucial piece of knowledge for how these images should be reviewed.
And the final takeaways for improving detection, looking at all those errors, it all boils down to diligence and process.
Right. Avoiding cognitive traps like satisfaction of search, recognizing subtle changes year over year with meticulous comparison, and always listening to and following up on persistent clinical symptoms.
So if we connect this to the bigger picture for you, we've detailed how human perception and interpretation are still, the weak link in a technologically superior process. Given this demonstrated difficulty in detecting subtle but invasive changes, especially ones that only show up on one view or are small enough to be obscured.
What future diagnostic tools might completely eliminate the human element of perception and interpretation error? And what new, unpredictable errors might those automated AI-driven systems introduce that we can't even begin to predict yet?
That's the challenge for the next generation of screening technology, isn't it? Trading human oversight errors for algorithmic certainty failures. Fascinating stuff. We'll leave you to think on that. Thank you for joining us for the deep dive.